So my name is Jessica. I'm a PA at PCU, and thank you all for coming to my presentation today on behavioral addictions. So the objective for this presentation are to define behavioral addictions, talk about some similarities between chemical and behavioral addictions as well as their differences, examine the most common behavioral addictions, and discuss treatment options and local resources. So as many of us know, addiction is a complicated disease. Addiction often serves a purpose for that individual, and it works on parts of the brain that trigger survival, and it is far more complicated than just choices someone makes. If you haven't already seen it, I highly recommend watching Katie Salvador's presentation. She kind of goes into this in more detail. So addiction can be someone's best friend. It can be someone's way to cope with life. A look into early childhood development and theories of psychology suggests that addiction starts with a lack of early bonding, a lack of confidence, a lack of self-esteem, recreational or prescribed use, and mental health issues. So the prefrontal cortex is a region of the brain that is involved in executive processes, and it's important in risk-reward decision-making. But it is among one of the last parts of the brain to mature. So compared with mature adults, this aspect of the brain development renders adolescents more vulnerable to addictions and other risky behaviors and mental health disorders. So addiction in adolescence can interrupt the maturity of the prefrontal cortex, and it can derail the normal neurodevelopment of that person. Sorry. So what are behavioral addictions? So behavioral addictions are also called process addictions. So behavioral addictions are activities that impact the pleasure centers of the brain, which are regulated by hormones like adrenaline, dopamine, endorphins, oxytocin. And chemical addictions are what we treat here at the Root Center. And these are using substances that directly work on the brain and affect those chemicals. So both of these are similar in that they cause chemical reactions in the brain, and they are used as a tool to escape pain. And they produce a tolerance, have withdrawal symptoms, and can also have devastating consequences for that individual. So both of these addictions can occur together, such as someone who has gambling use disorder, as well as alcohol use disorder. Another thing to keep in mind is that chemical addictions often have a behavioral component, such as someone who's addicted to cigarettes. They might have cravings for nicotine, a substance, as well as the behaviors associated with smoking. Similarly, I've had some IV drug users tell me that they enjoy the act of sticking themselves with a needle. So this shows that there is some area of overlap between the behavioral addictions and the chemical addictions. So how are behavioral addictions different from chemical addictions? So not all behavioral addictions meet the classic definition of physical addiction, but they do share some of the same psychological and social hallmarks of addiction. So with our patients on MMTP and MAT, the goal is abstinence. But with behavioral addictions, sometimes abstinence is not possible. And these patients do need to carry out some of these behaviors to some sort of degree, such as sex, food, shopping, exercise. Another concern regarding behavioral addictions is that patients such as our own with chemical dependencies might replace their substance of choice with a behavioral addiction. So think about our own patients and what kind of behaviors they might start to engage in when they're deprived of their addiction of choice, and any new behavioral substitutions that might start to appear. So for some treatment centers, there are not enough resources in place to monitor and offer support for these patients. So it's important to monitor for this during admission process, but also throughout treatment, because these behaviors can start to develop. So the criteria that classifies behaviors as behavioral addictions are similar to how we classify chemical addictions. There is a loss of control, repetitive behaviors in rewarding activities, or at least they're initially rewarding, persistence despite consequences, aversive states when they try to cut back, cravings to engage in the behavior. So when we're considering each of these behavioral addictions, it's important to draw that comparison to what we might see to someone who's addicted to opioids, for example. So these are some examples of behavioral addictions: gambling, kleptomania, pyromania, trichotillomania. And this is a broad topic with a lot of information. So I won't be able to get to every behavioral addiction, but we will go over the most common ones and you'll start to see parallels between them all. So addictive behaviors are hard to diagnose, treat, and often are not talked about as much as chemical addictions. This is thought to be partially due to experts having poor consensus on diagnostic criteria, which makes it difficult to come up with treatment options because we can't measure them in standardized ways. There also is a disagreement on whether behavioral addictions even exist, or are they classified as disorders of impulse control. Behavioral addictions are an emerging field of behavioral health, and a lot of information and studies seem to show that they are closer to chemical addictions, and they share a lot of features that chemical addictions have. And I expect that in the future, they're going to be treated more like chemical addictions. So treatment for behavioral addictions are similar to chemical addictions. Psychological therapies are the most extensively studied treatment in behavioral addictions. The core component of many of these psychological therapies are applied across behavioral addictions, while some of them are modified for specific addictions. So CBT works to improve control, decision-making, coping skills, and relapse prevention. Cognitive enhancement therapy shows significant improvement in impulsivity. Cognitive bias modification is also used, mindfulness-based stress reduction, dialectical behavioral therapy, which works by emotion regulation, motivational interviewing, psychotherapy, and 12-step programs. So research often shows that combining several of these therapies strategies are much more effective than just one on its own. And more recent neuroscience research supports that the treatment of behavioral addiction should be similar to substance addictions, and using medications such as naltrexone is more effective versus previous theories of treating it like OCD with medications like SSRIs. So the first topic is gambling disorder. So gambling disorder is the only recognized behavioral addiction in the DSM-5. There were other addictions that were considered, such as internet addiction, but there was poor consensus among the experts. However, I do think this will change in the future. So gambling disorder affects 0.4 to 4% of the population. It is more common in men, but the women that are affected are more likely to be older and progress faster. More than half of those with gambling disorder also suffer other mental health disorders. They are at a 6-fold greater risk for substance use and a 4-fold greater risk for substance use disorder. So this is something that we should be looking out for and monitoring for in our patients. So being in the new age of internet, there is a new risk for gambling disorder, as people can now easily hide their addictions behind a screen, and it makes it more difficult to detect. Offline gamblers that you would see at a casino are more likely to be older women, while online gamblers are more likely to be young men. Those who use both online and offline are more likely to be at risk for substance use disorder and other riskier gambling. So electronic gaming machines, like you see in the picture here, this is the most hazardous as they perpetuate near wins. It's also important to assess smoking status in your patients, as being smokers is associated with more risky gambling and more severe gambling. And suicidality is also associated with gambling disorder, so it's important to ask patients about that. So patients with gambling disorder can usually trace their disease to an early win. And this early win increases excitement. It makes them believe that they have special skills or luck. It gives them an illusion of control. And these patients also believe that a string of losses is going to predict an imminent win. They remember their wins over their losses. They believe in luck, and they believe that wanting to win so badly means that they're going to win. The picture shown here shows that the brain responds almost identically to a near win as it would an actual win, which shows why those electronic gaming machines are the most addictive. Right, so cravings from gambling are similar to cravings for substances, and then it hijacks the brain's functioning. And this is similar for most behavioral addictions. So the nucleus accumbens in our brain rewards our brain's reward, and that's our brain's rewards and reinforcement, which gets turned on and activated into overdrive and reinforces those connections with the insula. And the insula is what controls our survival needs. So this addiction starts to become part of that patient's survival. The brain starts saying, we need to do this in order to live, just like we need to eat and breathe. The PFC, which is the police of the brain, like we talked about earlier, it loses control of this system and it lets it run haywire. As abstinence increases, these cravings and system changes start to decrease. So Gray's theory is that some people are more sensitive to this reward system, and those patients are usually more difficult to treat. They're more likely to drop out of treatment. They have greater gambling frequency and social motives for gambling. This image that's shown here shows MRI scans of cocaine and gambling use disorders. And they're showing images of either gambling or cocaine and how they respond. And these brain changes are similar between the two. They show less blood flow and activation to the areas of judgment. So the DSM-5 requires 4 or more of the following characteristics to be present for someone to be diagnosed with gambling use disorder. These characteristics are similar to what we would diagnose someone with a substance use disorder. So they have to be preoccupied with gambling. They need to gamble in increasing amounts of money. They have repeated unsuccessful efforts to reduce or stop their gambling, restlessness or irritability when trying to stop, gambling in response to negative mood, chasing losses, lying to others to hide their gambling, jeopardizing relationships, careers, opportunities because of their gambling, and relying on the escape of negative financial consequences of their gambling. So legal activity is not necessary to be diagnosed, but it is linked to more severe outcome and resistance to treatment. Before diagnosing gambling disorder, it is important to get a good medical history to rule out medication side effects such as Parkinson medications, which can cause new onset disordered gambling. So most patients will only seek treatment after being pressured by family. There are many barriers to treatment, including stigma, shame, and the patients trying to handle the problem by themselves. Treatment for gambling disorder has a high dropout rate from about 43 to 80%. The combination of antidepressants and CBT seem to have the most success in keeping people in treatment. Even just motivational interviewing like we do with substance use disorders is shown to be effective in improving gambling outcomes. So that's why it's important to just screen for these and ask the questions. So there are some medications that have been shown to help with gambling disorder, such as SSRIs. These have mixed results. If a patient is bipolar, then mood stabilizers could be a good option. Opioid receptor agonists, like we use here at the Root Center, such as naltrexone, is helpful for urges, as well as its cousin, nalmefene, which is an injectable version. Other medications have been shown some efficacy, such as COMT inhibitors, which are Parkinson medications, ecopipam, which is for stuttering and Tourette's, NEC, which is for lung problems, and Tylenol overdose. And there are also Gambling Anonymous locations in Connecticut, which you can use this website and you can direct your patients to. So it is important to consider the link between alcohol use and gambling disorder, since these two often go hand in hand. It has been shown that the treatment of gambling disorder does decrease alcohol use overall. However, 31% of patients in this study continued to have risky drinking. These patients are less motivated for treatment, and they actually respond better to motivational interviewing rather than CBT. So the next topic is addictive sexual behaviors. So paraphilias are behaviors such as pedophilia, fetishism, exhibitionism that are deemed socially unacceptable by society. They often involve non-human objects, suffering, or non-consensual persons. Non-paraphilics are typical sexual behaviors that include compulsive sexual acts with multiple partners, compulsive masturbation, compulsive use of pornography, and compulsive sex and sexual acts with a consensual relationship. With technology advances, the internet can be used as a source of sexual addiction for patients through location-based online dating platforms, as well as pornographic videos. Addictive sexual behaviors affects 2 to 6% of the population. These numbers have gone up with the invention of the internet, and this addiction is more common in men, but unfortunately, many of the studies on this subject are done on men. So there needs to be more studies on women as well. 64% of these patients will have substance use, half will have anxiety, 43% will have childhood conduct disorder, which is aggressive, destructive behavior that often violates the rules in childhood. This is something that we could potentially be seeing in our patients. So addictive sexual behaviors is consistently linked to high-risk sexual behaviors. This includes STIs, unwanted pregnancies, loss of relationships, loss of self-esteem, losing jobs. And studies show that there's an impact on younger men, especially with easy accessibility to internet pornography. So erectile dysfunction in younger men less than 40 years of age is typically diagnosed as a psychogenic or linked to stress rather than a medical or physical cause. Studies show that there's been a sharp increase in erectile dysfunction and low sexual desire in men younger than 40, correlating to an increase in internet usage. So in 2016, a study was done with people from 16 to 21 years of age, and they were followed for 2 years, and they found that there was persistent problems in boys with low sexual satisfaction, low desire, and erectile dysfunction, almost half for each of those. Often we see erectile dysfunction as a side effect of methadone maintenance and opiate use. So it is important that we do screen these patients for pornography addiction, as it could be contributing to their erectile dysfunction. So internet pornography may have the highest addiction potential, second to internet gaming. The level of patients' arousal to internet pornography is the greatest single predictor of how severe that addiction will be. The pathophysiology of internet pornography is that the internet is a supernormal stimulus, which leads to hyperactivity of the brain and hyporeactivity and underreaction to the response of natural rewards, such as partner sex. There is a tolerance aspect that builds with pornography addiction, so these patients are going to need greater stimulus for sexual arousal, and this leads to sexual dysfunction, which can have significant consequences for that individual. So studies show that pornography use is inversely related to satisfaction with partners. A simple assessment for internet pornography-related dysfunction is asking a patient whether he can achieve a satisfactory erection and climax when masturbating without internet pornography. If he cannot, but can easily achieve these goals with internet pornography, then this could be the reason for his sexual dysfunction. So in an interview, you want to make sure that you are in a private environment, as this is sensitive information for the patient. You want to make sure you ask about these paraphilic interests, sexual history, and even possibly porn websites that they're interested in to get a better picture of any paraphilic interest. You want to ask the patient how much of your concern is about the amount of sex, what kind of sex, or what kinds of people you want to have sex with. You want to see how much is this preoccupying their thoughts, as well as relationship problems, self-esteem, and mental health disorders. It is important to get a complete medical and social history when diagnosing addictive sexual behaviors in order to rule out medical causes and medication or drug side effects, especially cocaine or methamphetamines. So the DSM-5 proposed criteria for addictive sexual behaviors includes criteria that has to be over a period of at least 6 months. This criteria includes excessive time consuming, fantasizing, planning, or engaging in this behavior, using the behavior as a way to regulate dysphoric mood and stress, being unable to control themselves despite the risk of harm to self and others, leading to impairment in life. This also needs to not be contributed to recreational drug use or a manic episode, and the patient must be at least 18 years old. So treatment for addictive sexual behaviors includes CBT, behavioral control, which includes thought records, psychodynamic therapy, and group therapy. Medications for comorbid mental health problems can also be helpful. SSRIs are common medications that are used for depression, and they have the side effect of reduced sex drive, which might be helpful for someone who's experiencing hypersexuality. Anti-androgens are reserved for men who are repeat offenders, and they may be a harm to themselves or others, as these medications almost completely eliminate sex drive and have serious side effects. Sex Addicts Anonymous is available through this website, and you can have your patients access meetings as needed through there. The next topic is internet and gaming addiction. So a 2015 report described a case of two brothers, 22 and 19 years of age. They were both high academic achievers, an upper middle class family who lived at home, and they both began playing online video games. In the first couple of months, they spent about 2 to 4 hours per day, but then this quickly progressed to 14 to 18 hours daily. The gaming started to interfere with their sleep and their daily routine, and they both started to deteriorate to the point when they engaged in the video games, they would urinate and defecate in their clothes. They would not change these clothes for days. They stopped bathing, they stopped eating, they skipped meals, and they weren't answering their phone. Eventually, these boys both failed their classes, and they started to become abusive and violent when their gaming was disrupted. Eventually, they were admitted to inpatient care by their parents for treatment of gaming use disorder. So internet gaming disorder has a high prevalence of about 8.5% of 8 to 18-year-olds. Comorbid disorders include ADHD, anxiety, depression, and social phobia. So the description and diagnostic criteria of internet addiction disorder first appeared in 1996. Many aspects of internet addiction and internet use deemed pathological in 1996 have become pretty normal today. The internet is quickly evolving, and through the use of algorithms and apps, people are spending more and more time on screens. If anyone has ever seen the documentary Social Dilemma on Netflix, it focuses on how big social media companies manipulate users by using algorithms that encourage addiction to their platforms. It also shows how companies use personal data to target users and get them to consume more content. Because of the internet's easy accessibility, convenience, absence of authority, this is now considered the medium of choice for many addictions, such as gambling, gaming, sex, and other addictions. So risk factors for someone who might be addicted to internet include characteristics such as high impulsivity, shyness, low self-esteem, procrastination. And if a patient has perceived lack of social support, feelings of isolation and loneliness, they're more likely to become addicted to internet genres with predominant communication features, such as social media. And this is something that can be relevant to our patient population, as many lack a social support, and they might be feeling even more isolated with COVID. So worldwide, the average person spends about 6 hours a day using the internet. This just came out last month. And a research study shows that 77% of American adults go online every day, and 26% of those are online almost constantly. So that's quite a lot of people. So internet gaming addiction was considered for the DSM-5, but experts could not come to a consensus. But the proposed criteria is met when the patient has 5 of these. And these are very similar to substance use, preoccupation, withdrawal symptoms, tolerance, unable to control in trying to stop, loss of interest in previous hobbies, excessive use, deception of family members, and they're using it to escape negative moods. And there also has to be some kind of significant effect on their life, whether that's a loss of relationship, job, education, or career opportunity. So treatment of internet addiction includes CBT. Specifically, there is short-term treatment of internet and computer game addictions. And this is a disorder-specific CBT individual and group treatment program that lasts 3 months, and it has shown 70% success. Pharmacological treatment with bupropion has been shown to help improve attention and impulse. And ADHD medications like Strattera and methylphenidate are also helpful. So as we all know, COVID-19 imposed lockdowns around the world, and the internet offered never-ending distractions for people who were forced to stay home. So most of the jobs and daily activities, such as shopping, transitioned to an online format. And almost all of the social interactions and connections with the world was through an online format. Even older generations, less likely for internet use, had been affected by this pandemic. A study conducted on subjects older than 60 showed significant increase in internet usage. A 64% rise in usage of online communications like Zoom and WhatsApp, and a 41.7% rise in using internet daily for errands. Pornography use also showed a drastic spike during this time. In 2019, Pornhub had 42 billion visits, roughly 5 times the world population, and this number has spiked since lockdowns. On August 28th, due to a technical error, Zoom had stopped working from 8 a.m. to 2 p.m., so when everyone's doing their working from home. And there was a peak of 6.8% increase in porn usage during this time. So the next topic is binge eating disorder. So a study evaluated over 1,000 university students for potential food addiction with a DSM-5 criteria for substance dependence criteria applied to food. So 12.6 of those met food addiction criteria, and 5% mainly consumed sugar-laden foods. Overweight and obesity was unrelated to the sugary food preference. So food addiction was concluded to result from unique individual characteristics that determined reward response to food and promoted excessive eating. Food addiction affects 0.2 to 4.7% of the population. It is more common in women, younger to middle age, and although they don't have to be obese, it is more common in obese people. So binge eating disorder is classified in the DSM-5 under eating disorders. They must have recurrent episodes of binge eating, defined as eating patterns during discrete periods, such as 2 or more hours, that involve excessive rapid food consumption, a sense of lacking control over their eating during the binges, and significant psychological distress. So treatments for this include CBT, individual group psychotherapy, behavioral weight loss if needed, if there's associated obesity, second-generation antidepressants, and lisdexamfetamine, which is a stimulant. Sorry, I cannot pronounce that. Second-generation antidepressants and that medication and therapist-led CBT increases the likelihood of achieving abstinence. So there are some treatments that need more evidence, but they can be used, such as Topamax and disulfiram, which are used in alcohol use disorder. Patients who have this can be directed to Overeaters Anonymous, which is a great resource. They have a lot of good information and local meetings. The next topic is compulsive buying disorder. So compulsive buying disorder affects 5.8 to 8.9% of the population, mostly female and younger in age. These patients are likely to have mood disorders, personality disorders, anxiety disorders, even substance use disorders, eating disorders, and impulse control disorders. So unlike ordinary consumers with primary buying motives of value and usefulness, compulsive buyers make these purchases to elevate their mood, cope with stress, and gain social approval, recognition, or improve their self-image. There are 4 distinct phases of compulsive buying. The person will be experiencing some kind of negative emotion, which will lead to anticipation, and then preparation, such as going to the store, and then shopping, which provides brief euphoria and relief of their symptoms, and spending, which can lead to debt, relationship problems, criminal behavior, and even suicide attempts. So although it is not in the DSM-5, the following criteria that is proposed for compulsive buying disorder includes preoccupation with buying, buying more than needed or can afford, just distress related to buying behaviors, significant interference with work or social functioning, and it does not occur exclusively with other hypomanic or manic episodes. So the YBOCS shopping version is a sensitive tool for screening. and you can use that for patients who you think might have this. So treatment for compulsive buying disorders include CBT, group psychotherapy, self-help programs, and unfortunately, pharmacological evidence is lacking. So the next topic is trichotillomania. So this affects about 0.5 to 2% of the population. It predominantly affects females, 4 to 1 in adults, but in childhood it can affect both sexes equally. Typical age of onset is 10 to 13 years old, and the average duration is 22 years. Symptoms are going to intensify and wax and wane throughout the years, but they mostly will persist without treatment. So the most common hair pulling sites are the scalp, 72.8%, eyebrows, and pubic region. More than 20% of these patients will eat the hair after pulling it out, and this can lead to the formation of hairballs and cause gastrointestinal obstruction called trichobezoars, which sometimes need surgical intervention for removal. The inability to stop the hair pulling and result in alopecia can lead to low self-esteem, psychological dysfunction, and social anxiety. So this image that I'm going to show is a trichobezoar, so just warning for anyone who might be grossed out. Oh, sorry. So there you can see it. It was removed. All right. So patients with major depressive disorder, anxiety, and substance use disorder. Trichotillomania is often misdiagnosed as OCD. In a large survey, patients sought to alleviate their negative feelings through pulling out their hair. So they started to use tobacco products, alcohol, or even illicit drugs. Also, 83% reported anxiety and 70% reported depression due to the hair pulling. So this indicates that clinicians should screen for trichotillomania and the secondary manifestations of the behavior in order to ensure that they're getting the right kind of treatment. So trichotillomania is under the DSM-5 for obsessive compulsive and related disorders. There's recurrent pulling out of their hair resulting in hair loss, repeated attempts to stop, and it's going to cause distress, and it cannot be attributed to another medical condition, such as a dermatological condition. And it cannot be better explained by some other mental disorder, such as body dysmorphia. So treatment includes habit reversal therapy, which can even be online using a self-help manual. Comorbidities should also be treated. And clomipramine, NAC, and olanzapine, dronabinol, which is a synthetic TCH, all of these medications have demonstrated some efficacy. So the last topic is kleptomania, which is compulsive stealing. So kleptomania differs from ordinary shoplifting because their stealing is motivated by symptoms of relief and not personal gain. So persons with kleptomania mostly steal from stores, usually items of little value, and then they either discard, hoard, secretly return, or give these items away. It affects about 0.38 to 6% of the population. And studies of patients with psychiatric disorders show much higher occurrence. So most kleptomania studies report female predominance. However, women are more likely to seek professional help, and the legal system is more likely to send female shoplifters to a psychiatric evaluation and male shoplifters to jail. Substance use disorder is highly comorbid in patients with kleptomania, 29% to 50%. And patients with kleptomania have first-degree relatives, usually with substance use disorder. So although this category is ill-fitting for kleptomania, it is classified under the DSM-5 diagnostic category of impulse control disorders, not elsewhere classified. So this is recurrent failure to resist impulses to steal, increasing sensation of tension immediately before committing the theft, and pleasure and gratification or relief after committing the theft. Stealing is not committed to express anger or vengeance, and it's not in response to a delusion or a hallucination. And it's not better explained by conduct disorder, a manic episode, or antisocial personality disorder. So there's not much data on the treatment of kleptomania, but it consists of educating patients that this is a lifelong disorder. CBT can be helpful, as well as memonine, which is used for Alzheimer's, and naltrexone, which has been shown to be more effective than SSRIs. There are groups that patients can join as well, which I've listed here. And without treatment, these patients are at risk for increased tolerance, so they're going to start stealing more and more items of higher value over time. And one study showed that 24% of persons with kleptomania have attempted suicide, and 92% of those attributed the suicide attempts to kleptomania itself. So this is something to ask about and look out for. There are also common legal consequences, including being arrested, as well as incarceration. So some other behavioral addictions include exercise addiction, in which patients use exercise to elevate their mood rather than for fitness goals. When patients do not exercise, this causes psychological distress. And a study done using brain imaging techniques examined opioid release and found that athletes who were scanned 2 hours after endurance running showed evidence of reduced opioid receptor availability in the prefrontal and the limbic and paralimbic brain structures. So this means that these receptors contain endogenous opioids from the exercise itself. So eating disorders can also occur with exercise addiction. And therapy is usually the first step in treatment. And the goal is usually moderate exercise, not abstinence, because exercise does have health benefits. So for some patients, it might be recommended to switch to a new form of exercise. So for example, if their exercise of choice is running, you might want to switch them to swimming. So tanning addiction is also a behavioral addiction. These patients will use tanning to manage their dysphoric moods and stress. They will often keep tanning despite consequences such as sunburns and skin cancer. The UV radiation induces endorphins, which leads to the addiction. An assessment for tanning addiction can be used with SITAD. And of people who use indoor tanning regularly, nearly 1 in 3 reported that they would find it difficult to quit tanning. Few treatments have been studied for tanning addiction, but it seems that motivational interviewing has been shown to be helpful. The disorder of pyromania requires the repeated fire setting, and it is associated with tension or arousal prior to the act, and some sort of relief and gratification during or following the act. Additionally, the individual must have some kind of fascination or attraction to fire. This is similar to kleptomania, and it's actually under the same diagnostic category in the DSM-5. So risky behavior addictions are also known as adrenaline junkies. So these are people who perform risky activities such as rock climbing, skydiving, and over time, they're going to need more dangerous activities in order to reach that same level of excitement. So the concept of behavioral addiction has grown in public awareness and clinical acceptance. It is an emerging field of behavioral health, and more research and consensus among experts in the fields are needed. I think especially in our field of work, it's something that we should be aware of and monitor for and screen for, and hopefully give these patients some kind of resources that they can use to get treatment. So here are my resources. And do you have any questions?
Jessica, it's Dr. Lev. Thank you so much. It's a plethora of information, and I would have to go over it again on video. But question: how common you think is transitioning from one type of addiction to another?
I don't have any specific research on that. That would be something that would be really good to look into, especially for our patients. I would think that it is fairly common, especially because it works on the same pathways and it's kind of the same disease progress. So I would predict it's fairly common.
And among patients who are struggling with opioid use disorder, is there any particular type of behavioral addiction which is more common and we should be paying attention to, trying to rule it out?
Mm-hmm. I think, for like alcohol use disorder, I think gambling use is probably a big one. And I think internet addiction is becoming such an important topic, especially with COVID. I think it's becoming more and more in isolation. So I think that's something that maybe we should screen for. But definitely gambling, because that can also lead us to ask more questions and maybe there's a bipolar diagnosis. So I'd say that. But I think it would be good just to ask yes or no questions for a lot of these behavioral addictions. And then we can go from there and kind of ask more in-depth questions if there are any concerning signs.
Okay, thank you. Any other questions?
Jess, I'm wondering, it's Dr. Brown, I'm wondering for patients with risky behaviors there who seem to get an adrenaline, an epinephrine rush, I wonder if there's any studies that show that use beta blockers in these patients, at least patients that don't have a history of depression that would be exacerbated by beta blockers. But I wonder if any beta blocker studies have been used in these patients engaging in high risk activity, especially, whether sky jumping or jumping out of buildings or something on an adrenaline rush. Any research that that's been done, or we can look into it and see?
Yeah, not that I know of, but I agree that's that would be something that would be really interesting to know. I'll look into that, and I'll also look into Dr. Love's question. I'll get back to you guys.
Great, thank you, Jess. Great presentation. Thanks.
All right, any other questions? If you do have any questions, please feel free to email me.